Next, we have Lucia with current gaps in coverage to talk about. She's the director at the healthcare program for the UC Center for Labor at UC Berkeley.
Hi, good afternoon. My name is Lucia. I'm the director of the healthcare program at the UC Berkeley Center for Labor Research and Education. Thank you for the opportunity this afternoon to talk about the coverage gaps in California today. Under the Affordable Care Act, we've seen historic gains in coverage. In 2012, 17% of Californians were uninsured. Last year, in 2016, it was down to 7%, and this makes California one of the states with the highest drops in uninsurance rates. Yet 3 million Californians remain uninsured. This is our best estimate as of 2017. There aren't actual data available yet. This is a projection based on CalSim, which is a microsimulation model jointly developed by our center and the UCLA Center for Health Policy Research using California-specific data sources. The largest group of uninsured Californians, or 6 out of 10 uninsured, is undocumented. Undocumented residents are not eligible for coverage under the Affordable Care Act, though under state policy, undocumented children and young adults with DACA are eligible for full Medi-Cal benefits using state funds. There are also nearly 1 million uninsured Californians who are eligible for Covered California, either with or without subsidies, but continue to remain uninsured, and those are groups I'll talk about more in my presentation. Another group of uninsured is the approximately 300,000 Californians who are eligible for Medi-Cal but not enrolled. That's a small share of the overall population who are eligible for Medi-Cal because we estimate that Medi-Cal has a very high take-up rate of more than 90% now. Prior to the Affordable Care Act, there were big differences in uninsurance rates by income, by race and ethnicity, and by age. The coverage expansions under the Affordable Care Act have narrowed those gaps to some extent, but in general, the demographic groups that were most likely to lack coverage prior to the Affordable Care Act are still the groups that are most likely to lack coverage today. Low-income Californians had the biggest coverage gains under the Affordable Care Act, largely because of the Medi-Cal expansion. But today they are still more likely to lack coverage compared to middle and high-income Californians. About 15% of Californians with income equivalent to $16,000 or less for a single person were uninsured in 2015. That compares to 3% of individuals earning $47,000 a year or more. While differences in coverage rates between racial and ethnic groups have narrowed under the Affordable Care Act, Latinos are still the most likely to be uninsured. 15% of Latinos in California were uninsured in 2015, compared to about 5% of white residents in the state. Kids and seniors have very low uninsurance rates in this state. Young adults experienced big coverage gains under the Affordable Care Act due to the expansion of parents' coverage to young adults and also the broader coverage expansions under the ACA. But young adults are still somewhat more likely than other adults to be uninsured. 3/4 of uninsured adults are working. Self-employed Californians and small business employees made the biggest coverage gains among workers under the Affordable Care Act, but together these two groups make up half of the uninsured. By contrast, they make up about 1/3 of the state population of working age, and so they're disproportionately uninsured. Uninsurance rates also vary greatly by industry and are highest in California industries like agriculture, restaurants, hotels, and construction. As shown earlier, we estimate that the largest group of uninsured Californians is undocumented. Approximately 1.8 million Californians fall into that group. Most of these uninsured and undocumented Californians are low income. about 62% of them have income below 138% of the federal poverty level, which is the Medi-Cal eligibility threshold for most adults. These estimates by income and our broader estimate that there are 1.8 million uninsured undocumented include those who are on restricted scope Medi-Cal, which only covers emergency and pregnancy-related services. This slide shows trends for uninsured Californians who are not citizens. So it includes undocumented Californians, but it also includes other immigrants, such as lawful permanent residents, who are eligible for coverage under the Affordable Care Act. So among non-citizens who were uninsured when they were surveyed, almost 9 out of 10 lacked insurance for the entire year. After immigration status, the second biggest reason for uninsurance in California is affordability concerns among those eligible for Covered California. We estimate that nearly 1 million Californians are uninsured and eligible to enroll in Covered California, so they make up about 1/3 of all of California's uninsured. About 400,000 of these Californians are eligible for premium subsidies, and another 550,000 are not eligible for subsidies. The second group includes some people who have income below 400% of the federal poverty level, which is about $48,000 for a single individual. These are people who aren't eligible for subsidies either because the premiums in their area are less than the maximum amount they're required to pay under the Affordable Care Act, or because they have an offer of job-based coverage. Several surveys of Californians who are eligible for Covered California but remain uninsured have found that the top reason for lacking coverage is affordability. Approximately 15% of Californians that were uninsured in 2015 tried to purchase coverage through Covered California. Among those who tried, more than 3/4 said they found it difficult to find an affordable plan. California has been a leader among states in its outreach and enrollment efforts under the Affordable Care Act, but limited awareness of subsidies is one continuing barrier to enrollment. Nearly 3/4 of uninsured subsidy-eligible Californians who were recently surveyed for a survey for Covered California were not sure if they were eligible for subsidies, or they falsely believed they were not eligible when they actually were. This is significant because those uninsured who expected to be eligible for subsidies were twice as likely to plan to enroll. Now I'm going to talk about some of the other affordability barriers for those eligible for Covered California. First, even among those individuals who know they're eligible for premium subsidies, some still find coverage unaffordable. Under the Affordable Care Act, premium subsidies are not tied to the cost of living in a particular area, and this creates challenges in regions with high housing costs in particular. For example, take a single 40-year-old who lives in San Mateo County, where the median rent for a studio apartment is about $1,900 a year. If this person has an income of $3,000 a month, that leaves $1,100 a month after housing to cover food, transportation, utilities, taxes, other expenses, and health care. This person would pay $290 a month for the lowest cost silver plan in Covered California after premium subsidies. So that may cause significant financial hardship for them to pay for their health insurance and other needed expenses, depending on their individual circumstances. Affordability is also a challenge for people who make just a little too much to be eligible for premium subsidies, especially if they're older. The Affordable Care Act limited variation in premiums based on age, but older people still face higher premiums. As one example, a single 64-year-old in Fresno who earns $50,000 would pay more than $9,000 a year in premiums for the lowest cost silver plan. That's about 18% of income on premiums before counting any spending they would pay on deductibles or co-payments. A third affordability barrier is that people with an offer of affordable job-based coverage are ineligible for subsidies through Covered California. The glitch is that the affordability standard is based on whether the coverage is affordable for the worker. If the family members are offered job-based coverage, they are also ineligible for subsidies, regardless of how affordable that family coverage is. When thinking about policy solutions and enrollment strategies to increase coverage, it's important to keep in mind that about half of uninsured citizens in the covered California income eligible range are uninsured for less than 1 year. People often lack coverage, as we've been discussing, for short periods of time when they are in transition, such as when they're between jobs or going through a divorce or other change in life circumstances. And these short gaps in coverage can have negative consequences, just like being uninsured for longer periods of time. So I raise this to highlight the importance of strategies to cover people during these short gaps as well as the longer periods of uninsurance. So my presentation so far has focused on the uninsured, but some Californians who have insurance also face challenges affording care. And so this is where I'm going to address Assembly members' choose questions about underinsurance. So last week, the Commonwealth Fund came out with the latest in their series of reports on underinsurance, and they've developed a measure of underinsurance to measure how well insurance protects people from medical costs. So this is about how much do people pay when they access care, not how much do they pay for premiums. And they define underinsurance as spending more than 10% of your income on copays and deductibles and other out-of-pocket costs, not including premiums. If you spend more than 5%, you're considered more than 10% rather, you're considered underinsured. If you're low income, earning less than about $24,000 for a single person, they set a lower spending threshold of about 5% of income. So this out-of-pocket measure is based on how much you actually spend on care during the year. They also consider you underinsured if you have a deductible that is equal to 5% of your income or more, regardless of how much you actually spend. And that's because a deductible may deter someone from getting needed care. So the Commonwealth Fund, using their survey, estimates that about 1 in 5 Californians, or 21%, is underinsured. That's somewhat less than the 28% nationally. When you look at other measures like access problems due to cost or medical bill problems, it yields similar estimates in terms of the share who are underinsured. And the problem of underinsurance is growing. Nationally, underinsurance has more than doubled since 2003. And a large driver in that is the growth in deductibles. As Ken Jacobs testified, deductibles in employer-sponsored insurance have been growing, especially at an even faster rate nationally than here in California, but also here in California. And in the individual market as well, deductibles have grown over time, with the exception that the share of Americans who were underinsured based on their deductible as a share of income peaked in 2012, and because of the cost-sharing reductions under the Affordable Care Act, then came slightly back down. But it's still higher in the individual market than it was in the early 2000s. Underinsurance rates vary by coverage type. This is also from the Commonwealth Fund survey data, which is national, and this data is not available for California alone. Among Americans ages 19 to 64, they found that underinsurance is greatest among those in Medicare and in the individual market. The Medicare underinsurance rate reflects that Medicare involves a lot of cost sharing and doesn't cover certain benefits like dental, vision, hearing, and certain long-term care services. But it's important to note that this report was focused on adults ages 19 to 64. So the Medicare underinsurance rate here is specifically for non-elderly disabled Medicare beneficiaries who have high healthcare utilization. A separate study by the Commonwealth Fund estimated that about 1/4 of all Medicare beneficiaries of all ages is underinsured, which is a rate that is similar to in job-based coverage. In the individual market, people who are not eligible for cost-sharing reductions generally have out-of-pocket costs that are higher than those who are in job-based coverage, as Ken Jacobs' testimony showed. And then Medicaid has very limited cost-sharing, especially here in California, but even minor costs can make up a big share of income for these low-income enrollees. So that's why this study found that 26% of Medicaid enrollees are underinsured. And again, these are national figures. Some states' Medicaid benefits are not as comprehensive as the benefits here in California. And the national trend of underinsurance in the individual market is confirmed by surveys here in California. For example, one survey of adults who were newly insured through Covered California in 2014 found that about a third reported that they weren't confident that they could afford usual medical costs, and more than half were not confident that they could afford major medical costs. So to review the key takeaways in terms of California's coverage gaps, we have made big coverage gains under the Affordable Care Act, but 3 million Californians remain uninsured. Gaps especially remain for the lowest income, for Latinos and other people of color, for young adults, and for self-employed and small business employees. 6 out of 10 uninsured Californians is undocumented. Many uninsured who are eligible for Covered California face affordability challenges, and 1 in 5 Californians who has insurance does not have adequate protection from financial costs. And this is most common in Medicare among the disabled beneficiaries that I described and in the individual market. Welcome your questions.
Thank you. Go ahead.
I have 2 questions for you, and both of them are pretty specific, and I hope and I think you'll have the answers to them. One is on the distinction between underinsurance and the uninsured. So I think between the presentations, what we've heard is we tout in California the fact that the uninsured rate has dropped more than half, right? Say 15% to 7%. But the underinsurance rates nationally and potentially in California have doubled during that time. So it seems that we're trading no insurance for potentially poor insurance. And I wanted to ask you, what's going on structurally within the insurance market that is making it so difficult to provide adequate insurance to that underinsured category?
Right. So the underinsured category is specifically those who have insurance. So when the uninsured category decreased, the number of people who had the potential to be uninsured actually increased. But in terms of the share of people with insurance who are underinsured, this has really been a long-term growth trend that predated the Affordable Care Act. I'm flipping through the report right now, but it started back in the early 2000s, and really the biggest driver is the growth in deductibles, and the growth in deductibles and job-based coverage in particular, because job-based coverage is such a large share of the number of people with insurance. So as Ken Jacobs described in his testimony, nationally about 60% of people with insurance have job-based coverage, and so as those deductibles have increased, both in size and in terms of the prevalence of the number of people with deductibles, that has driven the underinsured trend up.
And the reason for the growth in those deductibles?
And the reason for the growth in deductibles is the rapidly rising healthcare costs. Employers have shifted some of those costs to workers, and also taken on more of those costs themselves via higher premium contributions.
Okay, and I assume this is probably a topic we'll be covering in future hearings around drivers of healthcare costs. Second question I have, and I think hopefully there's just a number for this, 3 million Californians that lack insurance. I've seen estimates of what it would cost the state to insure them. Do you have any estimates, or at least a range of what it would cost us to cover those Californians?
I don't have a range. That's something that we intend to work on. I would echo the earlier comments that that expanding coverage, Medi-Cal specifically, to undocumented residents would be a short-term solution that would go a long way in filling this coverage gap. We did do an estimate in 2014 of the cost to the state in providing that expansion. It's outdated now, but one of the key findings from that report was that we called it a little investment goes a long way, because many undocumented residents who would be eligible if we expanded Medi-Cal are already enrolled in restricted scope Medi-Cal and eligible for emergency and pregnancy-related services. And those are the most expensive services, and we estimated that 60% of the cost of providing comprehensive Medi-Cal is already being paid for through restricted scope Medi-Cal, which is both state and federally funded. So the biggest costs are actually already being covered. The state would have to make an additional investment to cover non-emergency services, and that would be a very effective use of resources to get people the preventive care they need, the ongoing care they need for their chronic conditions, to really improve their health outcomes.
I'd appreciate if even the 2014 analysis, if you can get that to us. And I think I'd echo some of the points that were made by Dr. Arambula, that if we are able to provide insurance and provide earlier preventive care, that might even drive down some of the longer-term tertiary or emergency room care costs that we're spending anyway, even if we're not insuring folks, that could lead us to a better picture long-term. So definitely a conversation I hope we have in this select committee.
Thank you. You know, I practiced in Selma. It's the raisin capital of the world. You might not have been there before, but I practiced there because I was born in Delano in the middle of the farm workers movement and always wanted to come back to a community that helped to raise me. And so my question, if I may, really will focus on the Latinos and undocumented population, which you referenced earlier. And I wanted to get a sense, do they have the same percentage of job-based coverage that we're seeing in other ethnicities? Or is there something about the seasonal work that tends to go with agriculture and other employment sources that Latinos have that is helping to contribute to some of the discrepancies that we're seeing?
Right. Well, there's kind of three trends that come into play in that question. Latinos have much lower rates of job-based coverage, as Ken Jacob testified. We didn't have the data for undocumented immigrants in particular, but non-citizens have much lower rates of job-based coverage, and certainly that would, those rates would be even lower for undocumented residents. And as an industry, the rate of job-based coverage in agriculture is much lower than in other industries, and so all of those trends come into play in having lower coverage rates among the population you're talking about.
And I'd like to just share one anecdote, and then really I want to make sure we're being respectful of the public to give them enough time to comment with what we're saying. But there was a young patient who I remember taking care of who was in college when we diagnosed her with diabetes, but because of her underinsurance was not able to afford the prescription that we wrote for her. And it wasn't until her kidneys failed her in her late 20s that she came back to see me in the ER. It's a real disservice to our communities if we're waiting until systems fail, rather than helping people build the resiliency that they have within their own bodies. And so I'm trying to use this example only to say that my heart's in this, thinking of those 50,000 patients I took care of in my life, and know that we as a state must do better to help take care of them.
Just to piggyback on that, and I don't expect you to have the answer for this, so maybe it's more of a comment, but besides the human toll of people being underinsured or uninsured, there's a huge financial cost across society, because we know that it's much more expensive to give people treatment when they're further down the road to an illness, and also the economic cost of people who then go into bankruptcy or lose their homes or have to go on other kinds of social services because of medical costs is really hard to calculate. But it's unfortunate that within all of the talk of what it costs us to insure people, there's not an easy balance on the other side of showing the economic cost, not just the social cost, but the actual economic cost of having people be uninsured and underinsured. And maybe you have that, but I would think that it's much greater to not just cover them later down the road for an illness, but that ripple effect across communities and across all of the money that we pay towards other types of social service networks. So if you have any guess at that, but otherwise, then it can just be a comment.
Right. I don't have one single number for you, but there is a large body of research showing that when people are uninsured, they're much more likely to have medical bill issues. They're more likely to have medical debt. They're more likely to spend down their savings to pay for their medical bills. It impacts their ability to afford other basic needs. Sorry, forgetting where I'm going with that. In terms of the overall economic costs, that is one big category. Also, there's lost productivity when people are less healthy. There has been some research on people with health insurance having reduced absenteeism at work. That's one example of the broader ripple effect of economic costs that you're talking about, which is very real.
So I know we're constantly asking you to quantify something that is very, very difficult to quantify, but in the 2014 study or in the study that's going on now, is there categorized ailments that would have been preventative had someone had insurance before they get to the ER? So when we study, are we only looking at the ER visits? Are we looking at that category of opportunities missed and quantifying that in any way?
That's not a focus of our research,
Okay.
but certainly, there are conditions that are much more costly to treat if they're not caught early, and of course, there are much more adverse health outcomes when conditions are not caught early.
So we don't actually categorize those in any separate way. Okay.
Although I think you can make a generalization, which is when you look at our state's healthcare spending compared to other countries, we're not being cost effective. And so at some point, I look at the percentage of GDP and really wonder where those dollars are going.
Where the return on investment is going.
I want a little bit of clarification on Medicare. I'll go back to that for a second. You said that 25% of Medicare recipients are underinsured?
Right. When you look at the overall Medicare population, all ages, it's 24% who are underinsured, according to a separate Commonwealth study, which defined underinsurance somewhat differently for the Medicare population than for the other coverage types. In this study, they defined underinsurance simply as having out-of-pocket costs that were more than 10% of income.
Yet the underinsurance rate for California as a whole is 21%.
Right.
So it's higher for Medicare recipients.
Right. And that Medicare rate, though, is national.
National.
Yeah.
That's a national rate. So we don't really know what that is for California?
We don't have, there was an adequate sample size in the Commonwealth Fund survey to break down California-specific underinsurance by coverage type.
Okay, great. Thank you. Thank you very much. Any other questions for? Great. Thank you so much. Really appreciate the information. Thank you.